Uh, Also the only person who's been deeply involved in the issues of medical ethics at Guantanamo, who's a former military medical officer, a general, and we're really happy to have him. He'll present the case, and then we've asked our panel to sit up here because we've been told that the webcast people are looking at an empty table. And so they've been kind enough to sit up here, but I'll introduce them after Steve presents the case.
Okay, well, thank you very much, George, again, and thank you all for attending. And I want to particularly thank a number of my personal friends and colleagues who have taken time out of their days to be a part of this, because I think it's a very productive, I look forward to a very productive day. I'm going to give you a little background how I got involved with this and what the purpose is. As George says, I'm a psychiatrist. I am not a forensic psychiatrist. I'm actually adult and child and adolescent trained, and my involvement started in 2004. I was nominated, or to be considered for nomination to the position of Principal Deputy Assistant Secretary of Defense of Health. That's the, I guess, the number 2 position in the Department of Defense. And the interviews, of course, ranged over a number of topics, including Abu Ghraib. And got to see many of the material that had been gleaned and was being looked at. My position, and I want to set this out and hopefully conversation as we get to the end point, my position is that medics would not be involved in any of the kinds of conduct that ended up coming out that was so egregious, and that we were going to be firm in health affairs, which has oversight of the medical departments of both the Army, Navy, and Air Force. Marine Corps falls under the Navy, for what the conduct of medical personnel would be. And if we saw, heard of, understood, in any way discerned that torture or abuse was occurring, then we were going to exercise within our authority the responsibility we felt we had to. I did not get the job, and in February 2005, wrote an op-ed for the Washington Post about unhealthy silence of medics. And felt strong, still feel strong about it. I'm a Vietnam-era physician, and of course, there is much that still is a legacy of serving at that time in terms of what is now relevant and what our roles, responsibilities, and what we do in the military as we conduct wars where nationalism, insurgencies are themes. So over time, as one of the few physicians, senior physicians, who has spoke out against torture and abuse, and a psychiatrist, I was approached to advise defense attorneys on cases. And that's how I came to this case of Adnan Latif in 2010. Now, what I'm going to do is review the case, certain elements of it. The panelists and others have got more information, and I'll be glad to email it. But I want to out all the psychiatrists here so we understand that, because this is a complex case, and each psychiatrist, as you look at it, will have, I think, very valuable insight. So Dr. Lazarus, Dr. Sageman, and Dr. Metzner, who's here. All of our, I'm trying to think if I've missed any of the other psychiatrists in the audience. Dr. Annis, of course, George's son. All psychiatrists who have, in their practices, I know, confronted these kinds of very complicated cases that are management problems, difficult to diagnose, difficult to in fact, over time, provide and design good care, and where, unfortunately, there are bad outcomes. And I know that those of you, Dr. May, who has been acknowledged, understand that these kinds of cases often will have bad outcomes. Now, what happened was the Latif case was one Friday afternoon, the attorneys for this detainee, David Reams, who many of you may know, and a team from Covington and Burling who were writing his petition for habeas corpus, contacted me in a sort of a last-minute tactic to review the findings and decide, was Adnan Latif really capable of being, call him what you want, a combatant, unlawful, belligerent, illegal. I'm not sure what all the various terms have been used over the years, but could this guy have been a fighter? And because it struck the attorneys that considering that an injury he had had as a either an 11-year-old young teenager and the history he gave for seeking medical care in Pakistan, that he would not really have been considered by anyone to have been an eligible fighter. And so at this time, they thought that this would support the petition. I was called into the SCIF, the secure facility, where Sandra and I have spent as many hours as well, to review just hundreds of pages of medical records, interrogation files, and all sorts of other ancillary material, and to prepare an affidavit. And that's what I did. The petition was filed in the U.S. District Court. The habeas was granted, and that summer, and the military was ordered to release Latif. And the government appealed the case, and during the course, while the appeal was going on, the underwear bomber incident occurred, and the White House issued an executive order that no one would be returned to Yemen, and Latif is a Yemeni. And so he was retained in Guantanamo, and on 8 September of last year was found dead in his cell in Camp 5. And so we're reviewing this case as psychiatrists, as physicians, as the care of a suicide, which was ruled by an official investigation by the military, not a medical investigation. It was an investigation by the Guard, by the line command authorities. We do not have access to any medical investigation because as medical officers, we can separately do a review of a case under our regulations. We do not have access to that review, nor do we have access of the autopsy report. Short story on, I did not meet Adnan, so what I'm telling you is only what I was able to discern from the medical records, and then conversations, formal and informal, with a number of people in Guantanamo, including detainees who knew him. I mean, I have spent hundreds of hours there. I've met dozens of detainees, and so I've had a chance to have lots of conversations with them informally about things. And I'm never quite sure what I can say publicly or not publicly. The basic fact is Latif and his family were in a car accident in Yemen in 1994, the four of them in a small vehicle that went off the road into a ditch. They all lived. He sustained the most serious head injuries. and that was diagnosed by a Yemeni physician as you see, a broken skull but no brain injury. There are no reports of any other imaging other than a plain film of the skull. He was evaluated again in 1995 and noted to have some problems in terms of his sight and hearing. He continued to have very serious problems in the subsequent years. As the policy is in Yemen, there's a mandatory draft, and so he was evaluated by Yemeni physicians as part of his entry physical, as we do here, and he did not qualify medically for the Yemeni army. His parents decided that he was absolutely not improving. He was having all sorts of difficulties. They're vague. I've not been able to really capture all the different problems, but they were behavioral, mood, problems in thinking. He was not doing well in school, all sorts of things. And so they decided that the best specialty care that would be available to him would be in Pakistan, which was not uncommon. As I've learned over the years, there have been a number of people from Yemen who have gone to Pakistan for education, medical care, learning a trade and so forth. He went to Pakistan, and it was there in 2002 that in a raid that was done by the forces, he was picked up, and with that, as a large group of people were then subsequently imprisoned there, kept in jails, ended up in Guantanamo. When I've reviewed the various records, it's unclear to me. In fact, I'm trying to figure out again what I can say. It's unclear to me what the charges were implicating him, other than the fact that it seemed like the person who arranged for his trip to Pakistan may also have been recruiting fighters for the Taliban. And so there was, which happened in Yemen. Mark may know a lot more about it, but there were people in Yemen who were recruiting young men to go to Pakistan and Afghanistan, and a number of people went and had their travel paid and ended up there, and then they were swept up in these big raids by our forces and our allies, and some, of course, were also sold for bounty by other people and ended up in jail, and they ended up in Guantanamo. And remember, when we first opened Guantanamo, we had 850 people there. Now we have 164. So that's how he ended up there. It's not clear he understood why he was there. And during the course of the time, he was evaluated by a Guantanamo neurologist, noted to have these problems. All, as you can see, would be attributable to a traumatic brain injury, and or not clear if he had some other medical psychiatric problem that would have emerged anyway during his adolescence and early adulthood. He was found dead in his cell on 8 September 2002. There was an extensive investigation by the military. It's called a 15-6 that summarized the findings of that. Cause of death was suicide by overdose of paliperidone in Vega, an antipsychotic. Somehow or other, he was able to hoard these pills. There are 24 pills that he was accused of hoarding. But there are also other medications in his system: codeine, oxycodone, quetiapine, Seroquel, mirtazapine, Remeron, Celexa, morphine, lorazepam, just a number of drugs, all of which had been prescribed to him. And commonly, just as an aside, we have seen in reviewing these records that many of these detainees are just prescribed a laundry list of meds. He had a long history of what are really disciplinary, or we can think of as conduct problems, management problems. If you're running a inpatient residential facility, he would have been a very, very difficult patient to handle with, the aggressive behavior towards the guards, where he threw urine and feces, some assaults, not really serious assaults, hunger strikes on and off. At times he was diagnosed as bipolar, borderline, antisocial traits, traumatic brain injury. A number of these diagnoses were used. And as his treatment got to be more difficult to handle, there was an ethics committee convened by Portsmouth Naval Hospital, which is the supervising hospital for the Guantanamo clinic, so that it falls under the command of Portsmouth Naval Hospital District. And an ethics committee convened and decided that against his will, he would be treated with depot or intramuscular antipsychotic medication. He continued to be a management problem throughout that time, was kept at times in the behavioral health unit, and then would be, as the conversations occurred between the medical personnel and the guard personnel, decisions about how long he should stay in the behavioral health unit. Is this a psychiatric problem, or is this just a willful misconduct problem? And if the decision was it'd be a willful misconduct problem, then he would be transferred back to his cell. And that's how he ended up back at Camp 5. Now, during this time, of course, is when all we had a large number of hunger strikers that started, actually it was after this, but we still had hunger strikers on and off during this time. And occasionally they would, if he was on a hunger strike, he would go to the behavioral health unit. If not, he'd go to Camp 5. A couple days before he was sent to Camp 5, which is in that particular camp, the detainees are in individual cells. He said to the guards and to the medical people, I will kill myself if I am sent there. And the detention group commander, military police, Colonel Bogdan, made the decision that he would be sent to Camp 5, and I cannot find in the record what the position statement was of the medical group commander. There is a separate medical group commander, Navy captain, and a separate detention group commander, who more often than not an Army colonel, and then there's a one-star admiral who runs the entire facility. Now, the chains of command are not as clear as you understand in any organization they're not clear. So the medical group commander really did not have independent authority to say, look, this man is suicidal, I'm keeping him in the behavioral health unit no matter what. And that did not happen. He was sent back to the behavioral health unit and, in fact, was observed by guards. There was a suicide watch protocol that was put in place. That was extensively reviewed. There were shortfalls in that suicide watch protocol. And, in fact, he was found dead in his cell 12 hours later. And these are the findings of that investigation. Most important ones are that he was determined to conceal the contraband, which was the medication, and the assertion was that he had hoarded 24 pills in his underwear. And of course there were failures to follow SOPs. There was blame placed on the medical group. JMG is the Joint Medical Group. JDG is the Joint Detention Group. Colonel Bogdan commands the Joint Detention Group. I think I know we know who commanded the Joint Medical Group at that time. Interesting, a psychologist. The JDG was judged to have met. It has a strong training program. The medical group was judged not to have a strong training program. And the other assertion that was made by this investigation that the problems in care and the suicide were not attributable to the short rotations. Now, the senior personnel at Guantanamo rotate every year. Some of the senior people, if they're on, we call an accompanied tour, that is, they take their families, will stay for 3 years. But most of the people, particularly the admiral who commands the installation, only stays for a year. The other people who rotate in, the physicians and the guards themselves and the medics, can rotate on a cycle of somewhere between 7 and 12 months. And that varies by services and also if they're active duty, National Guard, or Reserve. But very commonly, the physicians, including the more senior physicians, that is the lieutenant colonels or Navy commanders, will be there only for a 7th-month cycle. Many of the psychiatrists are there only for a 6-month cycle. And so there's, I think, to be transparent here, obviously feel that it is very difficult to build a good patient-doctor trusting relationship, an effective relationship, when you have such a short rotation. And I personally, as a psychiatrist who's still does a lot of clinical, cannot imagine doing that with patients who are challenging like this, that have multiple problems, both neurological, central nervous system, and psychiatric, as well as their just conduct behavioral problems. So that is really the summary of the case here, and of a suicide, man who, complicated case, never understood why he was being detained in Guantanamo, had heard and understood that the court, the U.S. District Court, had in fact awarded him his petition, granted him a petition for habeas corpus, and that he expected to be returned to Yemen, and then continued to be detained, and in that course of time was able to overdose on these medications. And with that, we'll open it up for conversation.
Right. Thank you, Steve. Actually, we're going to open it up to our panelists. And our first one is Scott Allen. Scott was an active participant and speaker at the Conference on Military Medical Ethics here in this room in 2007, and talked a lot about the lack of trust, which we just heard about, and continuity of care, and a death cycle, as I think you described it. All right, Scott, go ahead.
Thank you. I do have a bio included, but I do want to point out my background as it's relevant to this case. I worked full-time in U.S. prisons and correctional medicine for about 8 years, and followed that with 8 years working in a state psychiatric facility. That said, I'm the token non-psychiatrist on this particular panel, so I won't hesitate to jump right in and offer my opinion on psychiatric care and diagnosis. I should also point out that prior to being provided with the summary materials by the organizers of this conference, I had no formal involvement with this particular case, so my comments are derived entirely from my review of the records, and I haven't discussed this case with anyone prior. It's Monday morning, so it's appropriate to some extent that we do some Monday morning quarterbacking. But as someone who has served as both a clinician and a medical administrator in a detention facility, I read this file and the summary of the investigations with no small amount of sympathy for the clinicians who were engaged in trying to manage this case over the course of time that he was confined at Guantanamo. Again, I said I'll leave it to my colleagues to speak more eloquently about the diagnosis, but only to say that the combination of an Axis 1 diagnosis of bipolar, but probably more problematic here, Axis 2 diagnoses of borderline personality disorder and antisocial disorder, rounded off with significant traumatic brain injury. It is a description of probably the most challenging patient class we see in institutions, whether they're psychiatric or they're correctional. Ironically, in my experience of those three diagnostic categories, it's the personality disorders that are the most challenging because we don't have particularly effective treatments for them. And in fact, cognitive behavioral therapy, others can comment on this, might be the most effective, but even that is far short of adequate treatment. So I think it's important for us to recognize that our professional colleagues at Guantanamo must have struggled in managing this case adequately. And in fact, as you review the file of their care, I will move on to the obvious shortcomings in care. But I also saw some evidence where people were trying really hard to do what they thought was the right thing. As I commented already, most of my observations come from the documents provided, and the most lengthy of them was a report, heavily redacted report from the internal investigation that Dr. Xenakis already referred to. They cited findings that were relevant that I concur with. I will mention them only briefly. And they attributed many of them to training. Specifically, there were issues on MedPass. Anyone who's worked in a correctional facility or inpatient psychiatric facility understands the importance of passing medications and observing that the patient takes them and swallows them and then monitors for hoarding, because this is not an uncommon behavior in these populations. And so they cite the training on those processes could have been better. Line of sight. When a patient monitoring schedule calls for line of sight monitoring, it's not it sort of sounds common sense, but it does require some training and understanding of exactly how closely the patient is to be observed. They cited problems there, and I concur. I disagree with their finding that and obviously Dr. Xenakis does as well, that the short rotations were not related to the outcome in this case. I actually see them as probably being the greatest contributor to the bad outcome in this case. This case, as I've already alluded to, in a civilian setting in a U.S. prison is also highly likely to have bad outcome. There are suicides in U.S. prisons, of course, and this wouldn't be an atypical profile of a patient who would be at high risk for suicide. And how you manage these patients in terms of the monitoring that we described does require both training and experience. Now, I've already said this is sort of the most challenging type of patient you can encounter in this environment. So I don't believe Dr. Xenakis noted that one of the officers who is charged with line of sight observation in the critical final phase was reporting for his first day of duty, and correct me if I'm wrong, I think later commented that he hadn't been completely trained on line of sight procedures, obviously directly related. The other and last comment I want to make about the investigation, and I look over towards my colleague Dr. Miles when I say this, when I first became involved in looking at the detention issues related to the post 9/11 wars, I had the opportunity to review some of the NCIS death investigations that were done on the initial reported deaths of detainees, which on the one hand seemed very thorough, but I noticed right away they so often began with, well, the patient was found unresponsive and a code was called, and then there's a very meticulous sort of review of how many chest compressions and was everyone trained in life support and so forth. They never seemed to go back in a probing way far enough. And to some extent, this investigation suffered from that as well. And I will now elaborate, because I think what I've set up until now are sort of the local issues that pertain to this case, but it begs the larger question that other people have been addressing today, and that is the context of this individual's confinement in the first place, and then as it relates to medical professionalism, the impact of the conditions of confinement on his deterioration and subsequent suicide. I think it's clear to me, and I think others will probably agree, that probably the most understated way I could say this is this environment was counter-therapeutic to this individual, given his diagnosis. That's the most restrained way I can say that. And it begs the question for health professionals working in these challenging environments that we've already started to discuss. And that is, what responsibilities do the health professionals have in addressing conditions of confinement? It is true, and we've already started to talk about, both in civilian prisons and in the military, that the understanding, either implied or explicit, for physicians practicing in those environments is that you are to, quote, stay in your lane, close quote. And by that, it's usually understood that you're to do what's clearly, obviously medical, but otherwise don't make any comments about what's going on. And I would like to point out that that's institutional, it's sometimes policy-driven, but I think Dr. Finn's already made this reference. I think it's largely cultural as well. Having practiced in a prison environment, these are isolated environments, they're most unnatural environments, and because they're security related and threats are a daily issue and safety and security are constantly enforced, anyone practicing in that environment starts to, whether they're aware of it or not, identify with the guard force and the security mindset. And insidiously that starts to affect your judgment and how you look at problems. So they're, from a cultural standpoint, certainly going back to the Stanford prison experiment, which certainly illustrated that phenomenon, this is a major challenge. And I agree, as I've studied this area over the last decade, that I've always been concerned at what you've already raised, that lawyers seem to have acquitted themselves better with these challenges than physicians have. That's a great concern to me. I think, just in closing my initial remarks, I think the practical direction we need to move or help the military move in is this issue that we heard about from Hans Wolf, this idea of increasing the independence and what I would say is the professional autonomy of the medical branch and their sort of system of reaching out for support when they raise challenges to custody. The final thing I want to say about that is to emphasize what I see as the affirmative responsibility of physicians to comment on and lobby for adequate conditions of confinement. In the United States, I currently live and reside now in the state of California. We've already heard about the Supreme Court case in 1976, Estelle v. Gamble, that established that failure to provide adequate medical care is a violation of the Eighth Amendment of the Constitution. The last time the Supreme Court reaffirmed that was in California recently with the California prison system. I have used those court decisions to emphasize to my professional colleagues working in prisons that prisons can't exist or be legitimate without the involvement of the medical profession. But what the medical profession has failed to do is leverage their foundational status in establishing the legitimacy of prisons to push for reforms in conditions of confinement. And that's something I think as a profession we need to do a much better job at.
Thank you, Steph. We have two more panelists, both forensic psychiatrists. I'm going to say a young one and an old one, but that doesn't sound right. I won't say that. Our first one is David Annis, forensic psychiatrist from SUNY Upstate. Dave.
Thank you, and I just want to say I'm very privileged to be here on this such renowned company, being a junior member of, I guess, our professions, and so thank you for that. I just want to say briefly, most of my experience in correctional settings has been in the state of New York, a lot during my fellowship in forensic psychiatry, and during that time I got a chance to work on a few malpractice cases, including a couple of institutional malpractice on against cases brought against correctional facilities. And so what I'd like to do is just look at that kind of through the lens of a malpractice case. The case with Latif, Mr. Latif, not necessarily here to criticize every little bit of what went wrong, what didn't go wrong, but I think it's a useful tool to look at a case like this. And so, looking in general at a tort of negligence, I don't like talking in a room with a lot of lawyers that know much more about this than I do, but just want to briefly go through the elements of what one looks at in a case like this. The first one, is there a duty? And I'm going to cross that out just because it's pretty much irrefutable that there's a duty of a confining facility to provide adequate medical care for someone detained in that facility. The basic premise is, you can't go down the street and find a primary care doctor. You can't leave. You can't go find an orthopedist to look at your banged up knee. So the confining facility takes on that responsibility. You can't go on the Obamacare website and sign up for your plan. Suppose neither can we, but that's, you get the point. So I cross that out just because there isn't really much of a controversy that there is a duty of some sort. And I'm also going to cross out injury and damages. I think suicide, the manner of death of suicide, certainly qualifies as an injury. And so I think what we're left with is, was there a breach of duty? And did that breach of duty cause this outcome? And so the sources for that we have to work with are, the main one being the Army Regulation 15.6 investigation report. Heavily redacted, but still a lot of information is left there, left in the report for us to review. And then when we're reviewing some of the regulations at Guantanamo Bay, there isn't a lot of that is classified, and there isn't much. So in a sense, sometimes we have to piece together, at least for a civilian like myself, where you get that information. So I've looked at a lot of the Freedom of Information Act released web sites. A site that has a lot of those documents. I just want to also state, for the record, I have not been to Guantanamo Bay, and unless I'm detained myself, I think it's fair to say I will not be seeing in the inside of Camp Delta. So certainly, just looking at these, and I have no firsthand kind of knowledge of any of this. And so the report, as I said, is heavily redacted, and there are certain points where you just look at it and you say, okay, we're not getting any information here. For example, there's a point where they're talking about one of the standard operating procedures about MedPass, and we have the several corpsmen indicated that they are, followed directly by, indeed, the Joint Medical Group Training Officer indicated that, followed by, directly, furthermore. So as you can see, it is kind of frustrating, but there is a lot left in the report. And so I guess that this guy did a pretty good job, or gal. I guess we'll find out in about 9 years. But despite that, there are a lot of important points that we get to see. And I'm going to just briefly mention a couple of places that we do get our standard of care from. When we talk about a breach of duty, we sort of look at it as, is there a violation of the standard of care? Did someone not meet the standard of care? And that's sort of how we look at it. And then the question becomes, what is the standard? And this is just a list of organizations that have come up with guidelines of what should be the standard of care. And I'm going to defer to Dr. Metzner for most of those. I believe he's going to talk about some of them. And there isn't a better expert probably in the world that could tell you about those. So I will do that, defer that. But it's just to show that there are some very strong opinions on that in general. But one can say, perhaps looking at, playing devil's advocate for a second, perhaps this detention center is a little different. And what if maybe they don't need to meet the standard of care that other people do. Maybe it's a very unique population, and in a lot of ways it is a very unique setting. But one way to look at this is to say, are they arguing that? Is as a Department of Defense, a Southcom, or anyone arguing that they don't need to meet a certain standard of care? And just looking at some documents that I've looked through, and this is one. This is an undated document that was in a draft about sort of when you get questions from the press, I believe, how you should answer them. And in this one, I think this is an older document, but basically they stated that when there was this argument about if the detainees were enemy combatants versus prisoners of war, whether or not you had to follow the Geneva Conventions, and they, even back then, because I think this is an older document, they stated, we don't have to do this, but we're going to follow Geneva III regardless. So you at least even back then are hearing them say, we're still gonna treat them as if they were prisoners of war, giving them that. And then in this Department of Defense instruction, it gets a little stronger, where it says that to the extent practicable, treatment of detainees should be guided by professional judgments and standards similar to those applied to the personnel of the U.S. Armed Forces. And so start to see that their own standard of care is pretty high. And then if we, and this is last updated, I think, July of 2013 on JTF Gitmo website. This fact sheet for detainee medical care states the medical care provided to detainees at Guantanamo is consistent with what U.S. service members receive, and there's no qualifications there. So I think that with those statements, you can sort of say, that they're pretty much on board that there are some very strict standards that they're going to follow, or they're going to hold themselves to a very high standard, which they should. And since this is a suicide case, I want to talk a little bit about, suicide in Guantanamo. Any correctional facility pretty much has to, it's understood that they know that someone detained is at higher risk of suicide than other places. So to not, in a sense, you sort of have to have some, it would be unacceptable to not have some suicide prevention program. And so, again, let's kind of play devil's advocate a little more and say, well, maybe suicides really aren't much of a problem in this particular place. And some of these numbers are very, it's skewed a lot because it's a very small population. But if you take the population of Guantanamo at the beginning of each year, and my source for that is the New York Times, and you just look at this annual suicide rate, so you have none for the first 4 years. Obviously, again, very skewed numbers, but you see some very high numbers come up. And then next to that, I've just put the Bureau of Justice statistics for the suicide rate for the U.S. state prisons for the comparable years, and these are per 100,000 per year. And so again, it's a very small detention center, and you look at that, and the numbers jump out at you, and might not exactly be a fair comparison, but I think it's at least shows that suicide's a problem, and that's something that needs to be addressed. And so, just to kind of play around with the statistics a little bit, and this is still very crude. One way to look at this over the basically 12 years is to say the average population at risk at the beginning of the year. If you take that as the population at risk for the entire time, the rate is 171. If you take the largest population from the beginning of the year, and it fluctuates, but for these statistics, it would be the beginning of the year of 2004. Then you'd have a 10-year rate, and that would be 107. And then if you took that number and then you just said, well, let's do all 12 years, I think you're being pretty fair at that point. You're sort of skewing towards there being a lower number, and that would be 89. And then the U.S. state prison average would be 16. And some can make the argument there's a lot of suicide rate in jails is a lot higher than prisons, but people don't, and this is a pretrial detainee center to some extent, but people don't go to jail for 8 to 12 years. So I think the prison is a better comparison, and I think that the numbers for jails are somewhere between 40 and 50. So you'd still have a significantly higher number at Guantanamo. And so one question we'd ask is, what sort of operating procedures are there to prevent suicide? Is there a program? Are there certain protocols in place? And I'm sure there are. We don't have a lot of information on that. At least I couldn't find a lot of information on that. There's the detainee hospital, some of those documents that were released. There's something about dealing with the detainee suicide attempt, and it's more about protocols directly afterwards, but there aren't a lot of details in that at all. In the March of 2004, Camp Delta Standard Operating Procedure Manual that was released, one of the few SOPs that we have from the area. There is something about emergency action plan. There isn't much about a comprehensive suicide prevention program, however, so there's not a lot of information. So there might be spectacular protocols in place, but we don't exactly know what they are. And so it kind of leaves us with the questions of, are there proper procedures in place for dealing with suicide? Were they being followed? And if not, why? And did lack of any of the above, either not implementing them or those not being adequate, did that directly approximately lead to Mr. Latif dying in the manner of suicide? And so there are a lot of ways to look at this, and even though the report is heavily redacted, sometimes we would look at the actual protocol being redacted and saying that that protocol is, we wouldn't know what the protocol is, but then we'd have it followed up by it was violated. So in a sense, we can know that some of these protocols were not being followed, even without knowing the full details of what they were. But at least in these areas, I think it's they lay it out pretty clear in the report. The med pass procedure, searches in the line of sight, and not following prior recommendations. And I'll just go very briefly into those. Oh, I'm already over time. Sorry. So the 2004 SOPs, and they might be completely outdated, but they do contain protocols for passing medications, mouth checks, making sure that someone doesn't, cheek the medications. I think it's fair to say that whatever the updated SOPs are, they're not worse than this. They're not less stringent, especially considering the problems with suicide that have happened on Guantanamo. We had Mr. Latif with 24 tablets of caplets of paliperidone in his system, which and he had a 6 milligram and a 3 milligram dose, so total of 9 milligrams. So he had at least 12 days that he was able to hoard those medications when this was probably during the time he was in the detainee hospital. And I think it's pretty clear that at least 12 times this wasn't done, unless he's is very good at kind of fooling people with that. And I think that's a clear violation where you can see if that was implemented each time, it would definitely limit his ability to hoard medications. The 2004 SOPs have things about searching detainees' cells after they leave, every time they leave, actually. Again, and then they have a lot of very routine searches that are very thorough, and there's about a half a page on body searching somebody, and he was transferred from the hospital to Camp 5, and most of his belongings were restricted from him. A lot of them were, and for all those searches, there wasn't. These medications were not found, and so there's also some question, that if he could have hid the medication in his underwear, there was another possibility that he might have hid them in the Quran, and there are rules about not touching the Quran and things like that among the force. But there are ways of doing that. You can call the interpreter to do it for you. You can ask the detainee to open it yourself, look at it. I think his attorney had stated that he would have never done that. It would have been blasphemous to some extent, but that is a possibility, and it doesn't look like that was done either. And then the line of sight reports. Basically, we don't have the autopsy report, but what's referred to in the autopsy is that he regurgitated onto his arm, and he had bilateral pneumonia. I think it's pretty safe to assume that was aspiration pneumonia from the vomiting. And the reports from the folks on line of sight, where you're supposed to have eyes on him every minute, state that one group said that they didn't look away for more than 5 seconds, and the other group said no more than 60 seconds. But if you have a guy that's vomiting that much, it almost defies logic that you would be able to miss that if you're actually watching or you're within earshot especially. And then a lot of what's redacted is the actual times that some guy goes from line of sight and he's relieved by another person. And one of the things is that people, and let's face it, really doesn't seem to matter much. You might say to yourself, well, this guy's, I'm looking at him, I want to stay here for 2 hours and not 3 or half an hour or whatever. As long as someone's looking at him, you figure he's safe. But there are specific trainings involved in this because it's really boring. And whether it's people falling asleep or what it is, it's people are a lot more vulnerable to that than they realize. And so those were not being followed. And then some were trained, some were not. And those that even were trained, some of the supervisors said, we're going to do it ourselves anyway, without knowing exactly why it was important. And it's the last footnote in the report, after the recommendations are listed, and it says, I'm just going to read it because it's hard to read in the photo. Recommendations, and then 8 of the recommendations from the investigation into the death of another detainee from the prior year, February 2011, basically they hadn't been followed, so they needed to be put in this report too. So they had put themselves on notice with a number of these issues and had not been they had not been addressed. And so I think when it comes to the psychiatric care itself, I think it's much harder to come up with a judgment on her standard of care and exactly if that was violated. We don't have the medical records. We don't have the autopsy report as well and some other things. But there are certain questions we could still ask. Was there a proper suicide risk assessment done, which is very important, of course. And we can kind of open that up to other, some other things. This is clearly a very difficult patient to manage. There's a quote the person's redacted, but the quote in the report that says, "Why is he not detained permanently in the behavioral health unit of the hospital?" And then again, we don't know who said that, but there's clearly some people who are of that opinion that perhaps he should have been there the whole time. And so I just was just going to put up a few. I guess that was it. A few remaining questions that certainly other people can answer that have been there, but just questions of the environment of the whole area and whether or not it is much of an environment where it is possible for someone to really provide proper medical care. What do the physicians have the power to do? And and I certainly don't have an answer to these questions, but I think there is certainly something that would need to be done, and whether that leads to what needs to be done is for it to be closed or some reforms, I'm not sure, but I'll certainly open that up for you. Thank you very much.
Thank you. Okay, and our final panelist before we all open it up to everybody else, Dr. Jeffrey Metzner, a leading authority on forensic medicine, prison health, and a senior figure in the field.
The old psychiatrist. Thank you. I just want to talk a bit about correctional psychiatry and how it applies to a military prison. And Dr. Annis had mentioned some of the standards of care. If you look at the American Psychiatric Association National Commission of Correctional Health Care, the first thing that comes as a standard is that medical practice has to be autonomous within the prison, within the correctional setting. And I know we're going to talk more about it this afternoon. That really is a basic issue here, that it is not. And when you compare military versus corrections, corrections is a paramilitary organization, but it sort of makes it look like the Boy Scouts when you look at military. And so you can go in a correctional institution and have problems, and it's cultural, and you can change the culture. But you go into Guantanamo, it's not cultural, it's structural. And so to change that is a very different thing than changing cultural attitudes. And so, and that is very problematic. And the other problem associated with that, if you go into jails or prisons and you call correctional officers guards, that's derogatory. And correctional officers want to be called correctional officers or deputies because there's a professionalism associated with that. And with it, that professionalism is particular training around health care and other issues. In Guantanamo, they're not correctional officers, they're guards. And they don't get the same kind of training. They also have a different culture and a different mission. And that's very problematic in providing health care. In corrections, it's well accepted that good security results in good health care results in the good security, and vice versa. If you have bad health care, that's bad for security, and if you have bad security, you're going to have bad health care. And at Guantanamo, what I want to address is system issues. And it finally occurred to me why the physicians aren't speaking up earlier. The reason they're not speaking up earlier, I'm making one assumption, that most of the physicians that go to Guantanamo for their rotation don't have correctional experience. There's a huge difference working in corrections than not working in corrections. Number two, even if you had correctional experience, you go into Guantanamo, which is probably the highest high-profile place. And if you have any smarts at all, it's going to take you 6 months before you even 3 months before you even know what the system's about. So you can't go in there and start making, even if you wanted to make changes in the first month, you have no chance at all. You got to build a relationship with correctional officers, with guards, with the chain of command. And the reason SOPs aren't being followed, besides them being outdated, you can read SOPs, and they don't translate into actions until you actually see a circumstance where the SOP is relevant. Because you look at SOPs, you may be reading 400 pages. And until you have a circumstance where the standard operating procedure applies, it's not going to make much sense. So it's going to take 3 months before you even have a feel for what this prison's like. And then you know you're leaving in 6 months. And so if you're going to make a change, you have about a 4-week opportunity during your 4th month. And probably by the time because what you're going to do what locum tenens do in prisons. Locum tenens are contract physicians. They come in and they have a secretary, a clerk, who says, I want you to see these 30 patients during the next 2 days. And that's what they do. And they have no orientation towards the system because they're only there for that particular day or that particular week. If you're a physician who's only going to be there for that 6 months in a high-profile facility, you're going to do what you're told, particularly when that's the structure of the prison to begin with. So you're not going to speak up, and if you speak up, you're going to be put down very quickly. Two other things I'll say. And we'll talk more about it this afternoon. But there are parallels in the civilian world of what you do with a place like Guantanamo. And if you look at any class action litigation in this country that involves supermax confinement, there is no plaintiffs have lost when it comes to putting people with serious mental illness in a 23-hour lockdown for months at a time. and plaintiffs always prevail, and there are one of two remedies. One remedy is you exclude people with serious mental illnesses from long-term lockdown confinement, or the other one, if you look at the Madrid case in California, is you change the conditions of confinement. So they're still in a supermax setting, but they're no longer locked down 23 hours a day. And the same should apply at Guantanamo. And in fact, although I agree that Mr. Latif was a very difficult person to manage, there's a lot of very difficult people to manage in corrections, and you have what's called special needs units. And I get very concerned when I read the discovery that I saw that at one point he was sent to, I think they call it the behavioral management unit, in which he was the only person there. I can tell you, if you're sent to a behavioral management unit where you're the only person there, all you're getting is confinement. You're not getting treatment because you can't provide treatment with just one person. That's not the nature of the treatment. And then the last thing I'll say is there are plenty of practice issues that were apparent from what I've read. There's lack of privacy, lack of screening, lack of suicide risk assessments. There was a rule violation in which the discovery said, I think it was the senior medical officer did an assessment to see whether there was any mitigating circumstances. Unless that senior medical officer, and he said, senior medical officer said it was volitional. Unless that senior medical officer was a psychiatrist, a non-psychiatric physician doesn't have the expertise to do that kind of assessment. And from what I read, it didn't look like it was a psychiatrist who did that assessment. So I think I'll stop there so there's enough time for us.
Thank you. That's great.
George, I'd like to just add one other
Absolutely,
thing, because
Steve,
these
go
are
for it.
great comments, and I really appreciate panelists' work here and diligence in what they did. I want to add another monkey wrench into the issue of conditions of confinement, and that is an old principle that really was a foundation of psychiatric care during the Vietnam War, of milieu therapy, which is how we constructed our environments in that time when we had, really innumerable patients coming back from Vietnam with all sorts of problems, and realized that the attitudes, values, rules set up in what we call the milieu had as much of a therapeutic effect as did the medications which we also prescribed and the verbal therapies. So this was part of the verbal therapy. Now, that is past. I'm talking about the principles of this were laid down in about 1965, actually, by an Army psychiatrist in the New England Journal of Medicine. And over the years, I've seen that fade in many ways in terms of inpatient psychiatric care. It's used somewhat in adolescent residential treatment care, but then that has also really morphed into a very structured behavioral management. Now, what is the relevance here is understanding some very important conditions of confinement, which are different than how detainees differ from prisoners. My experience, and Jeff, you and you, David, have much more experience, but when I go into a prison, mostly to evaluate a soldier or a veteran, I realize I'm seeing that around this man are people who are really dangerous and committed crimes in the American system. And they have been adjudicated. They understand how they're going to be adjudicated. And they understand the rules under which they are being both detained and will be judged. That's not the condition here. These people are not like prisoners that we see in our jails and prisons. These are people who are picked up from another culture, brought here, and are even today currently labeled as belligerents that, and I had a senior Department of Defense official tell me that even today these men are carrying out the tactics and strategy of al-Qaeda as part of a doctrine of asymmetrical warfare. And the guards, I mean, Colonel Bogdan said on a Guantanamo piece at 60 Minutes just a couple weeks ago, my principal objective is to protect my guards because these people are out to hurt them. So there are certain issues involved in the conditions of confinement that I think do fall in the responsibility as a psychiatrist who's trained in principles of milieu therapy. I cannot just defer them to the guards. And I think that's at much of what the tension is here as we think about where we're going forward.
Steve?
I'm going to pick a different issue. You know, we've been dancing around the classification of these documents, but there's a special class of documents here, and that's the death certificate and inquest report. Prison deaths are the canary in the coal mine for prison abuse. And in Geneva Convention 2, 3, and 4, there are specific articles that are related to the release of inquests and death certificates. And we systematically violated each of those conventions. The Armed Forces Institute of Pathology participated in the wholesale selective manipulation of death certificate report and selective release and false dating of those reports, as had the CIA. And that missing information, the death certificates and inquest reports in this case, are part of the reason that we are not able to make clear what's happening here. To give you an example, right after the Iceman's death came out, which was not properly reported, and indeed the death certificate was falsified, the Defense Department released 22 death certificates of at least their collection of 67. They released more than 90% of their natural deaths. They released 1/3 of their deaths by guards, giving the misleading perception that natural deaths were more common than deaths caused by homicide by guards. The release of the death certificate and inquest report in this case would tell us important things. For example, this man had aspiration pneumonia partly from these drugs. Was he restrained at the time of his death? Did he have a gag on at the time of his death? How long was it between the time he was put in his cell and the time he was observed? These are the kinds of things that go into a medical report. And in this case, the medical practitioners who were in on this case are part of a collective action which is designed to suppress these reports. And finally, this is not a standard of care with regard to the release of autopsy and inquest data that we would accept for our own POWs being held in any prison camp around the world. And in accepting it for ourselves, we are creating a new standard of care for world POW camps.
Thank you. I didn't think that was beside the point. I thought that was right on point. That's fine. Yes, Al.
I think the things that Steve just addressed need certainly to be considered by the final recommendations in the third panel and fourth panel, but I think the context of what Steve mentions is significant in that the death reports are significant, and we should, as a group, decide to do something about what you just suggested.
Well, if I may make one comment, after 2004, from the period 2004 to 2006, we had a 100% drop in death certificate reports, with the single exception being the Guantanamo site. We had a 95% drop in DOD notes, and we had a 98% drop in CID investigations that were released. Again, only from Guantanamo were the ones that were only released. We have not released any of the death certificates, CID investigations, or CIA reports from the CIA sites. We totally turned off in 2007, 2008, even press releases from Afghanistan or Iraq. We have wholesale violated 2, 3, and 4 of the Geneva Conventions, where we said that Iraq was going to be a Geneva Convention compliant theater of operations.
And I think the point you make, Steve, are very, very excellent, and we need to and somehow conclude that as part of our findings, if I may suggest. I have 3 points I'd like to make quickly. One is, I think the issue of autonomy for our providers in Guantanamo is key, and it addresses the points that the speakers made earlier with regard to structural institutional behavior. And if we had autonomy within the medical providers, this could be put aside. The second point is that although it's counterintuitive, it might be significant to consider that the people coming in on frequent rotations have an objectivity, if trained and educated correctly, about the situation they find when they go into that environment. Although the points being made, that that Jeff made about not understanding the environment until you get there and then work it, but the objectivity that new people would bring to the environment could in fact be the canary that things are not going well here. And the third point I'd like to make is that under the duty to protect under the Human Rights Conventions, during my time as ATF surgeon, I created a Delta Block, which was an inpatient psychiatric facility that did milieu treatment for the detainees. I don't know what happened in the past, but we did see the necessity of taking these psychiatrically ill patients, detainees, out of the general population and segregate them from the rest of society. Thank you.
Now's your chance. Dr. Grote.
I have a couple comments. First, I just wanted to follow up on this question of the JAGs and lawyers being independent and doctors not, which I think that when doctors and lawyers work together, as we know from GLP, a lot of good can come of it. But there's a danger of when the physicians and the lawyers are mutually reinforcing each other. The doctors say it's okay to do what we're doing because the lawyers said it was okay, and the lawyers say it's okay to do because the doctors said it was okay. And so you can go both ways. So you have to stand independent and work together. I disagree with Dr. Metzner. I respectfully disagree. In terms of the culture and situational aspects of the milieu, if you will, that allows some of these acts of perpetrators to happen. I've studied this for a long, long time in many settings. We have tertiary prevention, which is punishing the perpetrators, which I think we've had mixed success with, first of all, identifying and then trying to de-license and actually prosecute. But then we have secondary prevention, which is at-risk situations, high-risk situations. And I think that there may be some protection because of the turnover, 6-month turnover. But I think that Guantanamo is a unique kind of situation where the checks and balances are not there because you're isolated and you're not allowed to leave the institution, if you will. And so the world becomes a separate world. And we studied this in the Nazi experience, but also in Abu Ghraib, and in the Greek junta, and in Khmer Rouge. But there's a slow progression with the best intentions of a dangerous set of circumstances, individually as well as socially. And I just want to identify those, and then I'll leave it, and we can talk about it later. But from an individual's perspective, what we know is that there needs to be dehumanization, which is something that's universal in these situations where people start off with neglect, but then they move on perhaps to perpetration. So dehumanization, a splitting, an ability to separate out oneself in different scenarios, which is not the case in Guantanamo, which you can't kind of separate those two worlds. This numbing situation, the medicalization, which occurs. But clearly we know in the group dynamics that obedience to authority, which is something which is in the military culture to begin with, is very powerful when you're isolated and not allowed to escape that situation. Hopefully Dr. Beam can comment on that. Diffusion of responsibility, so this chain of command and taking autonomous. Forming the uniqueness of the group, so the specialness of the guards and the specialness of that we're doing a very tough job, and also the usefulness of training. And I can just, this will be my last comment. This is from the formation of a torture, which is a set of conditions which I think are germane to the Guantanamo situation, that this is created by the torturers themselves. Select for personal history of obeying authority, screen for intellect, physical strength, and positive identification with politics, bind with initiation rites, isolate, form new rules and new values, use elitist language, dehumanize and blame, harass, intimidate, and desensitize, promoting intuitive responses, reward obedience, demonstrate social modeling of group violence, regularize, and routinize. And I think those are all at-risk situations that are very germane to Guantanamo.
Jeff, do you want to comment on that?
I'm not exactly sure what you're disagreeing with me saying.
Just that the 6-month rotation, the fact that people are there for a short time, it protects, if you will, from some of the problems that might have occurred.
No, I didn't mean to imply that it protects from the. What I was trying to say, if you have no correctional experience to begin with, and you forget about Guantanamo, you go into any prison system in this country, it takes 3 months to figure out how to practice medicine within a custodial environment. You go into Guantanamo, which is a very high profile, very rigid, I assume, military structure. It's going to take at least 3 months. And if people which don't have experience speak up before that, they're not going to know what they're talking about, is my opinion. That's what I meant to say. Not that it justifies it, but it gives an explanation, I think, of why people don't speak up.
My name is Samar Chatterjee, Safe Foundation. I want to take another issue that you folks did come close to mentioning but didn't mention. What happens when that investigation report is completely fabricated and totally, because I've experienced one situation when I was in a detention, an attempted murder on myself was fabricated as an altercation because of what something that was said was irritable for the other person. And a civilian hospital, University of Chicago Hospital, physician who examined me said that the hit was so close that you could have died. So it was almost an attempted murder, you could say. However, the case manager who was in charge of the investigation, it was, I don't know what medical input she had, was written that I caused an aggravation and therefore I was beaten up. And the whole case, because of course the prison, and this is a federal prison situation I'm talking of, has a liability of being sued and paying for the damages and so on. They don't want all that. So they completely cover up and hush up an investigation, which would be a travesty in any open investigation. Not that many civilian investigations are not, including John Kennedy's murder investigation. But this happens in prison because it is a close. How do we solve that problem? Because there's got to be an outside investigation.
Well, in corrections, it's known as the wall of silence. And again, as a civilian, it's much easier for me to say, if I was in that situation, I would speak up, and because the worst that will happen to me there is I lose my job and I find something else. I haven't been in the military, but I know it's not the same thing in the military about speaking up and having no inconsequential consequences. And so I can't speak for what I would do in the military. I know in the civilian, that's what you do. And I guess what I would say, what you do in the military is you go through your chain of command and hope that that's going to work.
I would certainly think that there is room for more autonomy of medical from the command structure. And most of the issues that we are talking about seem to be these system issues that come up over and over again, whether it's an outside investigation, whether it's the culture, whether it's all the rest of it. And I would ask that we all make sure we're making the distinction of physicians who go in there, well-trained, trying to do the best job they can to practice ethical medicine, who would clearly refuse, because it'd be an illegal order, in order to give an inappropriate medicine or withhold medical care, but they are stymied in some ways, both because they're not familiar with it, practices that go on within that organization that at some point they will try to make a change, but it's almost commission versus omission sort of thing. And we are putting them in a very difficult position. That's not to say they shouldn't stand up and do what's right, absolutely. But they would, in the clear-cut cases, some of the others, by the time they figure out what's going on, they're transferred out. And that's almost everything that I've heard that's going on are those system issues. It's the command issues. It's the administration of the correctional facility, prison in this case.
Great. Tom, do you have anything to add on this?
I think I'd just tag on to what Mike was saying about the creation of a torturer, and I think it was Marina Harukos or something wrote about this under the Greek junta, and he outlined the things that you can do to someone to make them violate ethical and societal norms. And unfortunately, a lot of those conditions exist in Guantanamo and in prison situations where there becomes an us versus them and a dehumanizing and all of these things that we would prefer our folks never being exposed to. And I don't have an answer to avoid that. I think even the medical professionals in some situation can be sucked into that. And you look at the Nazi experience and the Nazi physicians, and it's terrifying for me as a physician to see what physicians were not only willing to do, but were leading the charge to do. So I think there is I think some of these situations are so extreme and so abnormal that we really have to try to figure out some way to shelter folks from these.
Bob, and then we're going to go to our panel and wrap it up.
I just want to follow up on what Dr. Beam was talking about. I mean, in the last 20 or 25 years, the field of behavioral psychology has documented time and again the power of the bystander effect. So I wonder, going back to Steve's opening comment, that the problems at Guantanamo are more structural than cultural, where you would put the bystander effect, because it seems to me that that's something that perhaps the structure needs to have the designated naysayer or the designated rotating people in from the JAG or from some other subgroup of medical ethicists to essentially confront the dominant culture that's allowed by the structure, if that's not too convoluted.
It's a question. You want to save it for your comments? Or? Yeah. Okay. So thank you all again. I will give a panelist one last chance to comment on the case or your comments, and then we'll break for lunch. Go ahead, Scott.
Well, I've spent a lot of time as someone who started in this business, as someone who worked in, at least domestically, in this environment. And I've really spent a lot of time thinking about how we've taken a professional core, those are colleagues in military medicine, who in my experience, both personally and as I've interacted with them over the years, as a group tend to be very professional people who have, compared to their colleagues in the civilian, as a group, more of a drive to meet ethical standards and so forth. How do we take a group of people who have these values and get these outcomes? And we've had a little bit of this debate between culture and institution, but of course it's a dynamic. It's a back and forth that, as you said, the institution defines the culture, but also the culture defines the institution. It's a little bit of a circular argument. And I leave you with just a teaser. I won't be speaking formally, but this afternoon the issue of hunger strikes will be taken up. I think my best evidence is the fairly recently released SOPs on management of hunger strike, which are ostensibly a medical document, but do not read as a therapeutic document for those of you who have looked at them. They are extremely adversarial. The framework they set up in the first sentences of the document talk about a battle with your patient. So I see that this is sort of being self-reinforcing. I think ultimately, yes, the difference between civilian prisons and military prisons is notable, and that the institutional weight in the military is much greater. But it is very much influenced by this culture, this mindset of being a country at war, and identifying with the medical professionals overly identifying with the security concerns.
David?
I just wanted to, state that, it's very easy to go back and pick apart every little mistake when there's a bad outcome, and there's a lot to look at in this report. There really isn't, I don't think anybody reading this report sees any individual bad intent, but you can clearly see how there are so many failures that happened individually, and then they all led up to, this bad outcome. And it's just just going back a little to Dr. Mester's comments about the systems issues. It's this very difficult to come up with the right answer, if there is a right answer to this. But I'm glad we're all talking about it at least, and maybe we will figure something out.
Jeff?
Three quick things. One, in civilian prisons, in mental health, the most common two issues that I have to tell trained PhD, MDs, psychologists, psychiatrists, is that when you're doing a clinical assessment, it has to be done in a confidential, sound setting, not at the cell front. That's always news to them because they're told that that's how they have to do it. Number two, that it's clinically contraindicated to put someone with serious mental illness in long-term 24-hour lockdown. That's news because we're told we have to do it. And then the third thing, to just answer David's question, setting up a mental health system in a supermax prison, there's a framework how to do it. It can be done. It has been done. So you don't have to reinvent the wheel. You just got to get the authority to do it.
Steve, wrap it up. Sure. Again, I want to thank everyone and start and try and just link Jeff's last comments with Bob's comment in terms of how you set up a mental health system in this kind of facility and sustain it effectively over time. One, it's good to know, and I, in fact, am in part surprised that there has been established and recognized framework for doing that in a supermax, because I don't think that in any of the SOPs or documents that I have reviewed, I have seen any reference to those models of care and experiences or lessons learned from those models of care, nor have I seen any criticisms in terms of what works or doesn't work. The implications are that the military system, and we see it in these cases, does not, in fact, primarily have expert capabilities in correctional medicine. That's not what we've done. We have taken practitioners who work in the combat theater or in our what we call fixed facilities, respectively, and moved them to this particular theater, and in a way characterized it as if it is a combat theater, and used the language of asymmetrical warfare to justify and label it as just another combat theater. So we've mislabeled what we're doing. And then we have not done what we tend to do in a very standard, conscientious way, is go to our other experts or consultants and guide us in how we're going to conduct provide our health care. Now, the last challenge that I think, if I understand what your remarks, Bob, have to do with what is a challenge for all of us in command, and how do we sustain the best command climate? How do we are able to organize our teams, our professionals, and understand that inherently that there is an up and down in terms of how well we do things, that there are going to be mistakes that we make, that there is going to be, strong word, corruption within we're going to get into bad habits, and how do we maintain a certain vibrant attitude and perspective that we minimize those kinds of problems. And we have effectively, as I've, at least in the commands that I've had, of course there are staff that have been there a long, long time. And then there's staff that rotate. And the art comes in the dialectic between those who are the institutional characters and those who are the newbies. And hopefully we get the right breed of contrarians who will add new ideas into that. The other, and that is not happening here. We have not set up those kinds of culture where that can occur. The other thing is, as we all know, that there are certain kinds of events that should alert us, and should alert all up and down the chain. And to me, I have not seen, and maybe General Blank has because of his role at USIS, I have not seen a good, systematic, thorough assessment review of the deaths in Guantanamo, either within the Department of Defense or outside the Department of Defense. You see, those deaths are an alert. They may be a small number, although the fraction is large, but when you walk around as a commander, and you walk around your unit, you see stuff that should pique your attention. And commanders realize that it's not a one-off. It's something that may lead to something else. And these deaths are the kind of thing that may lead to something else, which means that the Assistant Secretary of Defense of Health Affairs probably is responsible to conduct some review and analysis. Perhaps the respective surgeons general. Perhaps the Vice Chief of Staff or the Chief of Staff of the Army who has a separate initiative on suicide. Where are those reviews? Because that's how you, I think, institutionalize and effectively can be productive in using what our understanding is of the bystander lessons, and come in and know that this is tough work. I mean, I don't want to impugn or blame anyone here. It's tough, but it requires that kind of, I think, conscientious and careful attention. Thank you.
Okay, thank you all. I want to thank the panel. We actually scheduled for more than an hour and a half for lunch, but I'd like to try to do it in just a little more than an hour and 10 minutes if you could, because I know we're going to need more time this afternoon. So if you come back at 1:30, is that okay with everybody? Okay, come back at 1:30 and we'll start. Lunch right next door, right? Oh, what time? 12.
Yeah, so if we can, let's try to come back at a few minutes before 1. We'll go to 1. We'll go to 1 if we need it. Thanks.
Okay. I wasn't around.